the patients whose ACLs reattach perform better than those who don't and those who have surgery. Who actually needs surgery? It's impossible. The key message for patients is you've got heaps of options. Don't rush into early surgery.
So we're almost more lost than when we started.
Physiotherapists by nature are typically very conservative. In my experience, one of the risks of non-surgical is the patients can feel very good very quickly. We actually may be harming patients by inducing some of those and relying on some of those traditional theories. How do I step out of myself and be objectively introspective?
Do you really need surgery for your torn ACL or meniscus? I'm Matt Winter, Doctor of Physical Therapy, and today I'm asking a question that challenges decades of orthopedic tradition. So welcome back to the Best of Both Worlds Health and Performance podcast, soon to be the Performance Prescription. Today I'm joined by Dr. Kieran Richardson, specialist musculoskeletal physiotherapist, educator, and an expert in the world of non-surgical management of the knee. Today we're going to dive into what the research really says in this area, why public perception hasn't yet caught up, and what physios are doing to redefine what physiotherapy and rehab really means in this area. Welcome, Kieran.
Dr. Matt Winter, great to be speaking with you, mate.
Good to have you. We had a great chat a month ago where we kind of shot the breeze a little bit about what's going on in the world of physiotherapy. So it's great to be able to share this a little bit more today. I think we've all been there, either pitch side or our patients have walked in and told us of an incident where, you know, they're potentially the prime player in the team. There's no one around them. They twist their knee, they hyperextend it, they fall down in a heap, and there's this feeling of dread that comes over us and them. They say they've heard a pop, and we're like, this is terrible news. And within days and maybe a week, they're booked in for surgery.
Yes.
How has surgery become such an automatic response to this type of injury?
That's a very, very good question. And it really depends how long the podcast is, because we could probably spend the next hour unpacking that. I think there's been a few different reasons why surgery has become the dominant force and the first port of call. I think probably if we start with the elite athletes, because I think, you know, you spoke about, you know, we've all been there and we've all seen it. And I think from a mass media point of view, I think that's probably what has been the most compelling, would be the most compelling argument. Like you'll see these newspaper headlines or even online headlines now, and they'll say, after the incident, scans confirm the patient needs surgery. So they'll kind of have this language. And that superficially, that makes a lot of sense, especially when we're seeing the high profile, the athletes that we love, and we just don't really question it. And it's never really been questioned until recently. In fact, it's always, from a scientific point of view, we've always known for like the past 40 years that there are groups of patients who don't need surgery to function at a very high level. But since the 1980s, there's been industries that have built up that would perpetuate that media narrative, and there'd be a strong argument they're committed to not stopping. And so if you're a non-surgical expert, that's then, I guess, a bit of a clash of paradigms, because yes, you have that media narrative, you have the elite athlete narrative that a lot of us look up to, and then you have the industry and business systems that want to keep that as a monopoly. So I think if you put all that together, amidst other reasons, it's challenging to give a counter perspective.
I mean, it sounds cynical, doesn't it? If we take the sort of the theories out of it and look at the data, Kieran, are there groups of people that do better without surgery for ACLs? What kind of level of evidence do we have to say that we can go down this conservative route? And I guess we can probably split that into the new cross bracing protocols and just going through a standard conservative management?
Well, again, it really depends about the cohort that you're defining. So most people who injure their ACL are young active. So we're talking kind of 18 to 40, 45. And if you look at controlled trial studies where they compare people who have a reconstruction and then do physiotherapy, or people who do physiotherapy with the option of surgery if it doesn't work, if you follow those patients up long term, there's no difference, including for high level. So basically A-grade amateur, so just before professional level. Then if you sub-analyze that data, the patients whose ACLs reattach perform better than those who don't and those who have surgery. So
right.
If I write down on a piece of paper in crayon, surgery is good, and I bring that to a courtroom, it'll get tossed out. So it really depends on the quality of the data that we're looking at. So that's what the best data shows. When it comes to professional athletes, there was one prospective study from 2003, which actually looked at European handball, male and female patients, and that's the best study that's been performed in higher level, like professionals, and they showed no difference between surgery and no surgery in terms of return to sport. In fact, there was a slightly higher return to sport rate with non-surgical. But that ship's sailed, because basically, as you said in the intro, it's almost an unconscious decision for surgery at this stage when it comes to high level. And then I think a lot of us in the general population are looking at the higher level athletes. We see that happens with them, so we assume that must be better. And so I think a lot of physiotherapists, including myself, have been caught up in like wanting the data to change culture, and I don't think that's going to happen. And so there's other avenues which I think are better now, which I probably tend to spend more, I'm wanting to spend more time on, because I think a lot of the systems are not going to change. So it's more other alternative creation of media, creation of content, direct to patient content that I think's where I'm headed. Yeah.
So what do you think the best route is then to change perception? Is that going through the media itself? I guess that's what we're doing today.
Yeah.
What is our answer here as physios? And really, it's not just about physios, Dr. Kieran. It's about what's best for the public.
This is right. Yeah. So I do think research is important, because we can't just make stuff up. Like, we can't just say you can rub a rabbit's foot over the patient's knee and you'll get back to sport. Like, so that we could invent ideas, but we have to test them scientifically. So there's no question that we have to keep the scientific stuff going in the background, and we have to try to analyze which type of groups are going to be better with surgery, which type of patients are going to be better without surgery, which ACLs are going to heal, which ACLs need to heal, this kind of thing. So I think that is important. But I think for patients, podcasts, blog posts, social media posts, Facebook groups is a good example. So we've got one that we started in 2019 because every single other Facebook group was surgery, ACL surgery, recovery after surgery, failure after surgery. So we just thought, let's start a non-surgical one. Now we have 36,000 members. And so it's like, there's obviously a need for that. And so, and I've been on nationally publicized television interviews. I've been on large print form interviews, big podcasts. And I think that stuff is all a part of growing the tipping point, as the Malcolm Gladwell idea would be. I think you just got to keep going different streams. And I think sometimes, because I mentor a lot of physios, and I'm like, this weekend coming up and next in a couple of weeks' time, I'm traveling to the other side of Australia for the Australian Physiotherapy Association to run workshops on training physios in non-surgical ACL tear management. And I can quote the research ad infinitum, but it doesn't, I don't think that's the only solution, which I think a lot of physios get caught up in. And so I think for patients, they're asking simple things like, do you think this is going to work for me? The surgeon said surgery was my only option. What do you think?
But how do we then answer that question, Kieran? Because, okay, I mean, I think we one thing I admire about orthopedic surgeons is that they do tend to be quite good at putting patients into groups and boxes and prognosticating, because at the end of the day, they want good outcomes for their surgeries, right? Like we want good outcomes for our management. And I feel that a lot of the time they're able to look at structure and demographics and prognosticate based on those things about who's going to be a good candidate for surgeries. So, and I feel that we as physiotherapists have a responsibility to be able to do the same thing. So for the physios listening, and even for people that may have sustained an injury listening, who are the groups that can do better or do just as well with conservative management of their ACL tear? And what are the key things we should be looking at to reassure our patients that they are that person?
That's a good question. Do you want the scientific answer? Do you want my opinion? Or do you want the orthopedic answer?
I want all three.
Okay. So
tell me what the orthos would say first.
Well, the orthos will say if you're young, active, you need a reconstruction. They'll say reconstruction is the best way to return to sport. ACL tears don't heal. It's the best way to protect a meniscus tear. If you don't get reconstruction, it will increase the risk of arthritis. If you don't get reconstruction, you will end up needing a total knee replacement sooner.
I think those are the worst orthos. I think there are definitely some better ones. But yeah, carry on.
So that's the traditional orthopedic view, right? And there's recent research from this year actually where they looked at a survey of Australian patients who saw a physiotherapist, who saw a surgeon, and those themes were pretty common amongst. So I think you're right. I think not all orthos are created equal, but there is a majority where that would be the narrative. Okay, so there's that, and then if we take the scientific point of view, right? So we talk about prognostic indications. So how do we use a crystal ball, so to speak, looking at the research to try to predict who actually needs surgery? It's impossible. There is no way to predict it based on high-level systematic review meta-analysis. It's impossible. So there's a professor of orthopedics who probably is more in that minority where he gives patients a very balanced shared decision. He doesn't list off all those things I said just before. He'll tell the patients, look, you've got options. His name's Professor Ian Harris. And in one of his books, he wrote a book called Surgery, the Ultimate Placebo. And in his book, he said surgeons typically, they will overestimate the benefit of the procedure and they'll underestimate and undercommunicate the harms. So I think it's all well and good to want to have the science presented to patients, but then when the healthcare models are set up for the patients to get a 5-minute consult or a 10-minute consult, to be given these themes, to not have the research discussed with them, it's kind of like it's all well and good, but it just doesn't happen in reality. In a majority of cases, that's also been my experience. So what do I do and what does my team do? So we believe it's not really fair to spend 5 to 10 minutes with the patients and assume that they're going to hear and understand the research for their specific case. So we try to take our time with them, get them to ask us questions. So they normally come in with like five questions that they can ask us. At least I've had one patient write out like 3 pages, but sometimes the patients, because especially if they've started looking online into the research, they realize it's not as easy as like surgery is gold standard, which you often see presented by the reconstruction industry, that message. So I would say that for me, I have an hour, probably 15, 20 minutes is me asking the patients questions. Then I'll have a look at their MRI and see where the tear is, what it looks like, whether I think it could heal based on the studies, but also my experience. Then I let them ask me questions. Then I'll have a look at their knee, go through some basic tests, and then I'll generally give a summary weighing up the risks and benefits of both surgery and no surgery for them. And then I'll communicate that to them in a way that they understand without pressuring. And then almost always the patients will commit to like a 3-month rehab, prehab, if you want to call it that. And then we'll do another scan and see where they're at.
So what are those things that you look for? So what are the things you're looking for on the MRI, and what are those tests you're doing that helped you to inform that patient?
Yeah. So look, there's a couple of things, right? So from an MRI perspective, you can actually measure the tibial translation. So you can see how far the tibia has come forward. It's pretty easy to do. And then hopefully, if it's like, say, 10 millimeters or 15 millimeters, if you do another MRI, the tibia has come back, and then you're looking to see the shape of the ACL as well, like what the tear looks like. It's like there's various subclassifications you can look at for grade 3 complete ruptures. Some of them will look like real close, right? Some of them will pull apart. Some of them will start to flip, and some of them will flip both of the ends.
When a knee is like, when a patient is supine in an MRI machine, the tibia can translate forwards.
Yep.
That's mad. I'd not heard of that.
Yeah, it does. Well, you could think of it the other way, like their femur's dropping down. That could be another way to think about it. So like,
okay,
but yeah, it's like that. They call it radiologically. They call it evidence of ACL insufficiency. Yeah.
So that's what they're measuring when they say ACL insufficiency, is the femoral drop versus the tibia. Yeah. That's so interesting. Okay, that makes sense. Yeah. So you've got the distance of the tear, the femoral drop versus the tibia, or you can talk about the tibial translation forwards, and then the level of retraction. And I remember looking at the cross bracing literature, something to do with the tibial stump being intact.
Yeah. So there's like, it's interesting because the cross method is one method, right? That's gained a lot of traction, and we're friends with the authors, but we also believe that we should be telling patients that there's more than one way to heal an ACL. And so just another thing that I'm looking at for when the patients come in is their sensation of or episodes of instability. So if they've had the actual injury, hopefully they've gone into some kind of brace or at least on crutches or something, and they're not like just continuing to play on it, because you don't want them to like continue to keep having the knee buckle, because if it's gonna heal, we need to set it, or like have the patients psychologically be aware to not twist on their knee, to not force it straight, to keep it pretty still. And so I've had some recent cases of patients overseas where the physios have read the COPA versus non-COPA research. And so like 4 weeks in, the patients haven't had any episodes of instability. So they're taking them through the COPA v non-COPA testing. And the patients are getting like sensations of instability, doing like a single leg hop for distance. And so that's the kind of stuff that's the kind of stuff we don't really want to be doing. Because if you look at the healing literature, you can see healing from 6 weeks, right? In some of the papers. Some of the papers will say 8 weeks. I routinely do 3 months. But if you're getting the patient to like twist and run and jump, then it's like at more risk that their neuromuscular system's not strong enough or adequate enough, and their ligament itself may not be healed adequately as well. So you mentioned that the cross bracing protocol from Dr. Cross, right, is not the only way. So what other kind of bracing can we be doing for patients, or can they be doing themselves under our supervision? I think that's key. What you just said is it should be supervised. So some patients just want to start managing their knee injury on their own, and that's not wise. It's not smart. It's not safe. So basically, you can opt for rehabilitation with no brace. That is an option, and there are studies that show your ACL can heal without a brace. Okay, there's some bracing protocols where you have a specific jack brace where it basically does a reverse Lockmans and lines up the ACL that way. So that's one method you can do. There's another method where they just put hinges at the sides and don't actually restrict any of the range of motion. There's also a method that we're investigating here in Australia where we restrict extension. So we call it Blex, which is basically you block the straightening at between -30 and -40, and the patients can weight bear. So that's quite appealing to a lot of patients because they can get back to work, they can walk around, look after their kids, get strong. So we've settled on that, and we're not convinced. Well, there isn't any research that shows that -30 or -40 is worse than 90 degrees, or 90 is better than -30 or -40. It just hasn't been tested. So we're investigating that, and then hopefully in the wash-up we'll work out which type of tears need what type of bracing. But yeah, for now, I think patients, it's kind of a moot point what we do, because the key thing at the end is what the scan shows if we get that. And so, yeah, we're just hoping that they don't rush. The key message for patients is you've got heaps of options. Don't rush into early surgery. That's one thing haven't had too many patients regret waiting, because we can always at least prehab their knee.
But on the flip side, the cross bracing advice is that they need to get into that brace within almost like 10 days, right? Do you buy into that? And I know you've already said there's other types of bracing you can do as well. So is the key thing that after an ACL injury, we get these people into a brace? You also said that it can heal without a brace. So what should
There's also research that shows it can heal with nothing. There's some papers that show you don't even have to do anything, including no physio.
So we're almost more lost than when we started.
Well, I think what's clear is that some ACL tears can heal. And so what we really need to do is a large multi-arm, multi-center study where we're comparing all of these different types. That's the scientific answer. But I think the patients need to see a healthcare professional who's experienced and trained in non-surgical management. Do they have to? Is there research that shows these patients need to be seen immediately? Well, not very, very high quality science, but all the healing studies, they're seen within 3 weeks. So I think it's better to see someone who's experienced and trained sooner rather than.
Okay, let's move away from bracing and options for a minute and talk about rehabilitation itself. Okay.
Yes.
In that patient journey, what are your earliest priorities for that patient?
Well, it really depends on whether you're going either some kind of bracing method or you're just doing rehabilitation without a brace. Because if you're doing rehabilitation without a brace, you're not so concerned at keeping the knee at certain angles. You're just going on signs and symptoms. So in that group, you're wanting to drop their swelling, you're wanting to reduce their pain, get their range of motion back, get the patients to trust their knee, have normal gait, build up their strength, both legs and then the one injured leg, work on their balance. So that's the sort of stuff that you're doing.
So the standard rehabilitation progressions for a lower limb injury, right? So you get that swelling down so the quads can function, especially VMO, even though you can't selectively recruit it, but we know that swelling inhibits it. So we get that swelling down, we get the quads functioning again. And then I feel like quads get a lot of attention. Should we be putting more emphasis on other muscle groups, like hamstrings and their relative strength versus quads, and even gastroc, and do they prevent or protect the ACL as well?
They can. So basically, I mean, from a scientific point of view, I'm not too concerned about quads hamstrings ratios, especially with non-surgical management. That's just not been proven for that cohort. I'm really clinically and practically, what I'm wanting to do is get the whole leg stronger. So I'm thinking core, yes, like above the hip, but also hip, anterior, posterior thigh, medial thigh or groin, front and back of the leg, foot, so the whole thing for me. And ideally, it would be equivocal. When do the patients reach that? I think for non-surgical, it's typically quicker. If they haven't been braced, I've had some patients, and there's some case studies that the patients are ready at like 8 to 12 weeks. But am I comfortable with then putting those patients back on the pitch if they want to play sports? Not naturally, but I have had patients do it. So, and there's examples even quicker than that. But I like to take my time, and as you know, physiotherapists by nature are typically very conservative. So we try to hold the patients back as best we can. Probably, in my experience, one of the risks of non-surgical is the patients can feel very good very quickly, like almost to the point where they feel like there's nothing wrong. And so if you've got a patient or an athlete that's overconfident, they can be sort of chomping at the bit to get back on the pitch because they're like, I feel good. But if we haven't assessed that, if we haven't taken them through any protocols, if we haven't guided them through stage progressions, it's just more risky.
Yeah, it's interesting. I did the last podcast we did was on concussion, and a lot of the testing that we do there is almost to try and prove to the patient that they're not ready. It's how can you stress this system enough to show that you're not ready to hold someone back a little bit longer, which sounds awful, but it's for that person's own good. So what are you doing in your ACL management as your test to say, look, not yet, mate? Yeah.
Well, again, it depends which arm they're choosing. Like if they're choosing non-surgical, we obviously want all those things we mentioned. Like we don't really want any effusion. We don't want any swelling. We don't want any pain. We want full range of motion. I would want at least, and the research and the guidelines would suggest at least 80% strength of all those major muscle groups. I think it should be more than that. Like I'm wanting them basically equivocal. You want them to be able to pass the hop tests, although they're not the best. They're not the best. They've got some validity. And then there's psychological testing that you need to take the patient through. So, I just have time as a guide. Like if it's non-surgical, no brace, I'm thinking personally, even though the Swedish guidelines, which have the best data, they would suggest 3 to 6 months. I take the patients to 6 months before I release them. For pediatric, it's mandatory 12 months. But for young adult, I would say at least 6 months for that group. For braced, I tend to take it to 9 months because if you look at these healing studies, there's progressive healing from 6 to 9 months. And so I'd rather the ACL look more normal, more taut, more thickened. And then obviously you can do ligament testing as well in both of the groups. And the ligament testing, although it actually hasn't been shown to predict function, so if you look at metadata, it doesn't, having a solid ligament test doesn't actually predict someone's functional capacity. I would like it to be as stable as possible. And we see some patients where they'll have, say, a laxer Lockman's at 3 months, but then as the ACL keeps healing at 6 months, it's tighter. So I think it's just common sense that if you've got more passive stability, it's probably going to make your knee safer, I think. So, yeah, we prefer to let the patients we try to encourage the patients, I should say, to take their time.
I mean, it certainly feels right to do that. I know I do the same in ankle ligament testing as well. Why wouldn't you test structure as well? But then in the context of function and psychological readiness, so looking at it all as a group,
everything.
Right?
Yeah.
Okay, let's slightly move away from ACLs for a second and discuss meniscus. Menisci, and talk about, let's first of all, for those that aren't healthcare professionals listening, just discuss what is the meniscus within the knee, and then talk about does having a tear in the meniscus change our management?
How long's the podcast, Matt?
Yeah, I know. I told you, an hour and a half.
Yeah, and I've got to bail in 20 minutes because I've got another patient.
I know.
All right, so basically, the menisci are the cartilage-like shock absorbers within the knee. You have an inside and outside one. They increase the surface of the knee joint. They provide some cushioning for impact. Like we said earlier, the meniscus topic is somewhat controversial because based on research, right? So you have traditional orthopedic views on meniscus, and then you have research data, which is almost becoming a clash of paradigms, because we believed, and when I studied in the early 2000s, we believed that a meniscus tear was a very bad thing, and we believed that if you performed a meniscus test on the patient and it was positive, then that's also a very bad thing. And then we don't really want to let that patient not have a scan, because once we scan them, then we can find out what the type of tear is. The challenge is a lot of those ideas have been debunked from a very good research perspective. And then we're realizing that potentially not only have we been led astray, but we actually may be harming patients by inducing some of those and relying on some of those traditional theories. So I can unpack that a bit more, but yeah.
Let me kind of dive into it a little bit with you. I feel that the where I'm kind of at with it is that if a patient is not having symptoms of locking, that the knee is not repeatedly swelling, they're able to restore their range of motion within the first, say, 6 weeks, actually past 90 degrees at least, then I sort of keep them on that conservative pathway. It's the repeated locking episodes and repeated effusions that lead me to think, okay, this person needs a scan. And then we can dive down into types of tears later. So does that align somewhat with how you think, or is?
Well, it depends what we're talking about, because you've got chronic degenerative tears and research for that, and then you've got acute tears, so acute traumatic incident, right? And you got research for that, but then you've also got the research that talks about locking and like a symptomatic meniscus tear, and then how we treat that. But then you've also got research that shows when I MRI a knee, what does that do? Like simply the fact that we've ticked the box on getting an MRI. So just talking about getting an MRI. Unfortunately, there's like 3 RCTs now that show that once you get that MRI for that patient, you're setting them off down a path of likely having surgery, regardless of what the scan shows.
Yeah.
So again, you have that clash, because when we start talking about meniscus tear types, if it's an acute meniscus tear, if you speak with a die-in-the-wool surgeon, they will say that there are certain meniscus tears that absolutely need to be repaired. So they have a phrase
root tears.
Yeah. So they'll say like root tears. They'll go, repairable meniscus tears need to be repaired. So that's kind of the phrase that they use, right? And superficially, it makes sense. You go, okay, yeah, for sure. All right. But then you start thinking about that for a second. You go, well, okay, why? And then they will give you a reason that's typically bioplausible. But then my follow-up question is, okay, well, let's talk the research for that and the high-quality research for that. And if you've looked into the research, which I know well, the research doesn't stack up. So
tell me what are the outcomes there?
Okay. So again, it all depends on our frame of reference. Because if I show a tear on a arthroscopy or on an MRI, I then do a procedure, and then I do another arthroscopy or I do another MRI, and the tear looks better, then we can say that treatment worked. Superficially, you're like, oh, for sure, that treatment worked. But what if I have another patient who does a totally different treatment, gets the same method of assessment and has a similar outcome? Or what if I have a patient who has a meniscus tear, I do another MRI, they still have the meniscus tear, but they're completely pain-free? So it gets a bit more complicated once you start thinking about it more deeply.
But then the argument I would imagine from the orthopedic side would be, yes, but what are the negative consequences down the line? So, okay, yes, sure, they're pain-free now, but let's what about 10, 15 years later? What's the risk of arthritis?
Again, so if you look at acute tears, so like traumatic meniscus tears in young adult population, isolated. So the best research would suggest that doing physiotherapy without surgery for the majority of meniscus tears that present in clinic, if we do that for 6 months, so you said 6 weeks, so you could be selling yourself a bit short, because in these studies they did it for at least 6 months. You will get most of the patients, 75% of them, don't need surgery.
Sorry, Kieran, my 6 weeks is about restoring range of motion.
Range of motion, yeah. Okay, that's cool.
Yeah.
That's cool.
Yeah.
But if you have a group of, if you do get range of motion, and the patients get better, like hopefully the patients just continue on that path, right? But in this study, the study by SCU, they looked at, they did a sub-analysis of that study. They looked to see, did they actually develop arthritis if they didn't have surgery? And they didn't have any worse arthritis, whether their meniscus was resected, like cut out, whether it was repaired, or whether it was treated with physiotherapy. So a lot of the surgeons that I've had discussions with, and even some debates with, they will say, if I don't repair that root tear, the patient's going to get arthritis. But then if I look at the quality of the research that they're using to justify that decision, it's very low quality. So what we don't want is the patients to just be running around, like I said before, for ACL, doing whatever. It needs to be controlled. Ideally, as you're saying, you should have progression so the patients aren't getting worsening signs and symptoms. And then I think there will be a group that need to have surgery. But whether they need to have it early, we can't say that based on level 1 data or RCT data.
And can we predict that group, or is it just that monitoring of symptoms and signs over a period of time?
This is where it's challenging, Matt, because you'll have some people who will jump up and down and they'll say, if I don't repair that patient's going to get arthritis. But the discussions often become circular, because you'll go, well, you're just basing that on a crappy, like, your opinion. But if you actually look at the best studies, no, it's a wait and watch and rehab. Yeah,
and I think that's what I'm getting from this conversation as well. You know, I think we're desperate, and especially when we want to be seen as experts, and some of us are experts, to be able to give clear direction, to give clear prognostication to patients.
Yeah.
And we want to be able to say, if you fall into this group, into this bucket, you're going to end up like this. But what I'm getting from this is that it's actually a lot more nuanced than that. And it's a lot about being sensible, watching and waiting, gradually progressing, and then doing that within a context of how the patient feels about the process as well.
I think in an ideal world, that's how it should look. I think that's what healthcare should look and feel like, Matt.
Anyway,
unfortunately,
for
for anything. But unfortunately, the Philbay paper from this year is pretty damning. Like, you'll see the patients who go down the traditional medical pathway, everything we just mentioned, it doesn't happen. Like, it's like we're talking like it's a chop, let's get in, let's get it done. And they're not really given an ethical shared decision-making process. So I think it does make sense. And I think from a research point of view, but also practically, we can always choose surgery later. But if it was that easy, we wouldn't see increasing rates of meniscus repair, increasing rates of ACL surgery. But the rates, at least in Australia, they're increasing, despite what
that's
evidence would say, what the
mad,
guidelines
given
would say.
Yeah, that is mad given everything we're reading. So
yeah.
And then just very quickly talk about combined injuries. So if I think one of the indications for going surgical versus conservative is a
from a research point of view, or from a research point of view, or from an orthopedic tradition?
From an orthopedic traditional point of view.
Yep.
And therefore some of that's leaked into the advisory papers, right? So if someone has a meniscus tear,
this is where
and
it's
an
even
ACL,
more.
they need surgery.
Well, this is where it's even more. It gets even more challenging the deeper you go down the rabbit hole, because you see those advisory papers. If the entire advisory group is a group of surgeons, then obviously it's going to be conflicted. If you have advisory groups where it's a balanced team of people who are advocating for non-surgery, then you typically see it more balanced. But if you analyze the Kanon study, which is the RCT with the longest term follow-up, where they're looking at isolated versus meniscus tear. When there's an addition of a meniscus tear, there's a paper in 2017 where they looked at that, and the patients who had a meniscus tear were better to wait and do exercise. But that's, again, a lot of that. When you start looking at how these papers are also received, I've met these authors, and I know the authors well. Professor Richard Frobel who was the lead author of the Kanon study. He said, Kieran, we just wanted to be balanced and have an open idea of what we should do with patients. And if you meet any of these Scandinavians, they're typically like that. They're pretty pragmatic, and they're pretty, they don't want to kind of commit one way or the other. And he said, look, we just wanted to look at it scientifically. And he goes, when the paper was released, which showed no difference between physiotherapy and surgery, he said there was outrage. And he goes, we were just presenting the science. But he goes, it wasn't the science that people wanted to hear. And so it does make sense. Again, like if we're talking orthopedic tradition, you will say, if there's a meniscus tear, I need to repair that. I'm not going to do the meniscus repair unless I do a reconstruction. So that is their training. But there was papers in the 1990s that show if you put the patient into a weight-bearing protocol, the majority of ACL tears, ruptures, confirmed on arthroscopy, will heal, as well as meniscus tears will heal if you put the patient into a weight-bearing. So we've known this for like 30 years. But
sorry, if you put them into weight-bearing?
Yeah. So if you actually brace the patient,
the meniscus needs the weight-bearing to heal.
Yeah. So there's some Japanese studies that have shown that both on MRI and on second look arthroscopy. So they go in, they identify the meniscus tear, they identify the ACL tear, they then stitch the patient up, put them into a brace, do physiotherapy, do another arthroscopy, go back in and look and see if they've healed. And they did that with second look arthroscopy, but also MRI. And so a lot of these ideas maybe aren't new, but are just people are becoming aware of them. So it's like, the question for me, Matt, then is, how do we sit with this idea that this research has been, I guess, hidden, and then we've had a lot of these guidelines that have been set up, but maybe haven't been supported by evidence. And that's what you'll see is a lot of these healthcare models are set up first and then retrospectively tested, as opposed to testing them and then rolling out, which probably should be the most ethical approach. But that's not how it works in reality. Yeah.
Yeah, I get your drift. I do get your drift. I'm so interested in what you said about the meniscus there.
Yeah.
The weight-bearing benefits its healing process.
Yeah.
And you also spoke about bracing. So can you just clarify what you meant about bracing them to allow for the healing, and also the benefits of weight-bearing on the meniscus? And you also said that menisci can heal, and I think there's been an understanding that only in certain zones of the meniscus can we get any healing. So can we just quickly unpack that?
Yeah. There's a few things that are shot out there. So the red zone theory, where you have like red zone, like pink zone, white zone. So I'll throw back to you. Do you think that was ever tested?
I imagine
in good studies?
Or is it more like... I'm going to guess the answer is no from the way you asked it.
Pretty much.
But yeah.
Pretty much. So there's a paper, which I can't remember the author, but it was either last year or this year, where they looked at perfusion through the blood supply to the menisci. And they actually showed that the blood supply does extend all the way to the inner white zone, which was something that we didn't know or realize. And then in these Japanese studies, they had them in weight bearing, right? And then the patients were in the jack brace I mentioned earlier. It had combined. There's some cases were PCL, some cases were ACL. The PCL they did anterior translation. For the ACL they did a posterior translation. And then they had weight bearing as tolerated, and then they saw whether the menisci healed. So the majority of menisci, both medial and lateral, healed. That's one part, right? But then you have this whole yeah, then you have this whole other discussion. There's a really interesting paper, Horga, Horga, from 2020, and they showed that from about age 40, a lot of patients are getting meniscus tears with no symptoms, which you see across the body in MSK, and that's pretty well known that you can have degenerative change just as we age. But the Horga paper is interesting. They actually have bucket handle tears that are present in people who are completely asymptomatic. So just to flip the script, the size of the tear doesn't also correlate to the signs and symptoms, because we think, oh, this patient's going to have clicking, locking, and that's going to be because of the meniscus tear. But they showed that this is in like 200 odd patients, and these patients had never had symptoms, but yet some of them had bucket handle tears. So I think we want to pin it on the meniscus, and this is why and if we really want to crank open the conversation, we can talk about what has meniscectomy done to the knee when you have a part of your meniscus removed, what actually happens. And there's multiple very good research studies that show, and in fact, there are authors who are arguing to cease meniscus because of the harm that it causes. Because once you cut out part of the meniscus, it then leads the knee to become arthritic. So not only are we maybe not helping the patient, we may be harming them. And that's where it gets pretty serious. And so as much as I love talking about the papers and I love wanting to inform patients, I think when a lot of these industries are set up, we want to well-meaning present the studies, but for the patients, they may just be on a path that it may not actually, they may not be getting unnecessary care. They may be about to be harmed. And there's a strong argument with reconstruction, it's the same. So like, if we talk about arthritis, this is debated. Like, if I've been a part of scientific debates, and it gets really, sometimes it gets a bit heated, because if you're looking at the best studies, there's a strong argument that reconstruction may be increasing arthritis. And then there's some, as we said at the start, there's some surgeons who will acknowledge that, and then there's some surgeons who will not acknowledge that. So it's like, it's for patients though, I think, like what we've been saying in this podcast, I think the key message is waiting, watching, rehabilitating, and then seeing how your knee performs. I think if we do that, most patients are going to be glad that they've waited.
And I mean, I want to be clear here. Like, I'm not pro physio. I'm not anti surgery.
Yes.
I'm not pro either camp. And I
Yes.
think as physios, we've got to be really careful not just to want to bang our drum and
That's
you know,
true.
make out that we're the answer and orthos are bad. I don't think that's the case. I think our job, especially as we move towards first contact, and we are first contact practitioners, but as we cement that, it's so important that we stick in the middle and try and choose the best possible intervention for that patient at that time.
This is true.
Yeah, and so I've had discussions with, in fact, very recently, an orthopedic surgeon, and I said, look, I want this patient to come and see you to get another surgical opinion. And he was like, look, this patient has an ACL tear, but you know, this is her age, and this is her background, and this is her amount of, you know, instability episodes. Don't touch her. Like, as in, I don't want to touch her. Like, she'll be better with you. 4 or 5 months, she'll be back and she'll be snowboarding, you know? And I love that. I love to hear that. And when I start hearing orthopedic surgeons saying, I don't want to touch this person, I want you to manage it. And likewise, when I hear physios saying, you know what? Actually, you really need surgery. Like, I'm done with you. When we get to that point, then we're working in a model that's serving the patient and not ourselves.
I think you're right. I think in an ideal world, we would have all of these services presented to the patient, and then at the end of the day, the patients can make the decision that's right for them. And then hopefully, maybe with the use of AI as well, we can have very good research that can help predict which type of patient needs what type of treatment. And as you said, I think the last thing we want to do as physios is be anti-surgery. And the last thing we want to do is hem the patients in to to non-surgical as the only option.
Yeah.
And I think there are some orthopods, we call them surgeon heroes in Australia, where they're advocates for the non-surgical space. And I think if a physio's out there and they're passionate about this topic, it is good to have those allies across the aisle, so to speak. And I think you kind of need them, really. But given all the stuff we've spoken about, I think it is easier said than done. Yeah.
Yeah, they're out there. And I think, we need to be mutually respectful between ourselves and understand that, hopefully most of them are doing their best for patients. Most of us are doing our best for patients. We can learn from each other, but we've got to get away from any attachment to what we're doing.
Yeah. And I think this is the whole idea, right? Is they talk about equipoise. So what is, how do I step out of myself and be objectively introspective? And how do I look at a case and think, I want to remove my biases. I want to remove any conflict of interest that I have. And I want to put this patient in the most objective, on a balance of probabilities, what is the best thing for this patient? And I think as healthcare practitioners, if we're doing that, we can't go wrong. Yeah.
I love that. On that note, that's a great way to finish. Equipoise. Kieran, thank you so much for your wisdom in this area and kind of helping us explore the nuance and the sort of shades of grey in management of the knee. I think that's a brilliant start. Let's do it again.
Sounds good, mate.
Cheers. Thanks a lot.